Good afternoon. I'll be speaking about minimally invasive orbital surgery. You must be wondering what is minimally invasive orbital surgery. Orbital surgery is always done with big incisions, and it's said that big surgeons do big incisions, but it's not always so. You have to kind of triage your incisions and the way you do surgery depending on the tumor. I'll be mainly talking about injectables and minimal access surgery itself. Injections, of course, we all now understand that they have come in a big way in management of orbital tumors, but we have to select out patients. It's not that every patient would need an injection, and in situations where lymphangioma or veno-lymphatic malformation is injected, we have to be sure of the diagnosis radiologically with MRI. Otherwise, we may inject in cystic lesions which may look like veno-lymphatic malformation but not really so. We have had cases of adenoid cystic carcinoma, solitary fibrous tumors, etc., or even neuroblastoma with cystic degeneration coming with multiple prior bleomycin injections done elsewhere. So that should not be the situation. But once you're sure that based on the history, like this patient had unilateral proptosis of the right eye with recurrent subconjunctival hemorrhage, all documented proptosis since childhood, with even an episode of a chocolate cyst acute hematoma. Now she wants cosmesis. She's just about a young adult now, but her tumor is all over the orbit, around the optic nerve, lacrimal gland, SRLPS complex, medial rectus, lateral rectus, intraconal, extraconal. There's no way we can safely debulk this lesion. So all we did, because it is intraconal, we trust picibanil more than bleomycin. You can see nice clearance of the intraconal space, completely extraconal space as well, and she got the cosmesis that she wanted. So this is a very simple clinical situation where injections can be given. Now, if a patient comes with an acute orbital hemorrhage because of a pre-existing veno-lymphatic malformation, then we aspirate it with or without radiological guidance. In an intraconal posterior lesion, radiological guidance is definitely important, but if the lesion is anterior, then you can do without it, and we would keep the needle right into the lesion. We don't disturb the needle at all once we aspirate, and then we change the syringe and inject bleomycin. So generally, earlier I would inject the equal amount of bleomycin. Now we reduced it to even half or 1/3, because you always get the second chance if the patient doesn't resolve. There are very rare reports of optic neuritis following bleomycin injection, so we don't want to have such complications. We can inject half of it. This was a patient where surgery was attempted elsewhere and it was abandoned because of heavy bleeding, and this patient, all that was needed was an injection of bleomycin. Again, acute bleeding, but in this patient the blood was clotted. It was not aspirable, so we had to do a small incision and evacuate the blood, and as we did that, we injected in the cavity, and this patient also resolved well. This is an anterior lymphangioma, again veno-lymphatic malformation, again treated with bleomycin. Now that works well. Now this is a case where there is a roof of the orbit missing, right? Of course, by history and the being a triradiate lesion in a child, peripheral blood smear being negative, so we have a presumptive clinical MRI diagnosis of it being eosinophilic granuloma. But then treatment of choice would be curettage, and here the dura is already involved. You can see that curettage would be very difficult, and even if you do it, you will be incomplete in curating it, and if you send it to a neurosurgeon, then obviously the child will suffer a lot of morbidity. So how do we do it? Of course, IHC is confirmatory for eosinophilic granuloma, but an ophthalmic oncopathologist who is well experienced in reading out would be able to give you a diagnosis under frozen section squash imprint cytology within 10 to 15 minutes. Suppose they are hesitant about the diagnosis, we can defer the injection. But since the pathologist is confident and we trust the pathologist, we can wait for about 10 minutes following this biopsy, which is done from the safe middle of the lesion, and inject right into the lesion under visualization. 3 months later, there is partial remodeling of the bone. 6 months later, there is complete remodeling of the bone and complete resolution of the tumor without any need for major surgery at all. So intraoperative diagnosis actually helps minimize the intervention. One more similar situation, exactly managed similarly. Now for orbital lymphoma, this is a patient with predominant conjunctival component, but not to miss this subtle lesion which is hugging the eye and going back very posterior between the SRLPS complex and the eyeball, lateral rectus and the eyeball, and the medial rectus and the eyeball, and superior oblique was infiltrated. Of course, if you challenge any surgeon, he would go ahead and remove it, but what are the consequences? And do you want to give radiation unnecessarily, right? So anterior component can be easily removed. We have pathology confirmation. And for the posterior component, we can inject rituximab. This patient was managed with 5 milligram per ml, 6 injections of rituximab, 3-weekly interval, and there was no residual tumor. Now dermoid. Dermoid is a surgeon's delight. But what if a patient doesn't want surgery? This child has a lesion which is temporal. Now even with a lid crease incision, she is going to have a visible cut mark. There is no way we can go through this incision, hidden lid crease incision, and expose this lesion, which is actually adherent to the periorbital. This is one more young adult who has a similar lesion, but this is actually a dumbbell dermoid. I'll show you a video where how we do this sclerotherapy technique. Now we have to be sure on MRI that it has fluid content, not pultaceous content which is not aspirable. There's no point opening up to evacuate it, then it becomes very messy. So you can see this nice fluid content in this dermoid, which is aspirable. We mark the epicenter of the lesion, then we do it. Then we foam sodium tetradecyl sulfate. The needle is left in situ. The needle was inserted into syringe only for demonstration purposes. So needle is there in this thing, and then this is foaming, 1 to 5 foaming, and it is injected right into the lesion. And this is a different patient where you can see nice resolution of the dermoid following this injection. 1 to 3 injections are required. On an average, 2 injections are required for complete resolution. For surgery itself, for orbital biopsy, sometimes you have to make large incisions to get to the epicenter of the lesion. But then if you have image guided technique where you can use this technique, you can make much smaller incision, because now you know that you're right within the lesion when you do an incisional biopsy. Smaller incisions also are permissible when you use image guided technique. For the surgery itself, we rely more and more on transconjunctival approaches rather than open orbitotomy with lateral orbitotomy, bone cut, etc. This was a child with orbital teratoma, and diagnosis was quite obvious because you have this fully grown molar tooth right within the lesion. This was a tumor which was both on the medial as well as the lateral side of the optic nerve. Now this is the incision that we have made, lateral canthotomy, a small cantholysis, and an inferior phonacial incision. The lateral rectus and the inferior rectus are all tagged. That's the lateral cystic component with a very thin wall which could be dissected by blunt dissection. As we went medially, we could actually see the optic nerve which was not touched, left intact, and further medially we had this solid component which was easy to excise. This is the groove through which the optic nerve was passing. So we did not even have to dissect it from there, it got separated. This child resolved very well, his disc edema resolved, and all we need to now do is correct his esotropia, which probably is fairly easy. This was a young lady who wanted no scar on her face at all, but she wanted relief from this tumor that she had. Here we again did transconjunctival approach. She had a visual field defect as well with disc edema. That's the lateral canthotomy incision, and inferior cantholysis, and a transphonacial incision. Fornix is not like you don't go right into the fornix, but we have about 4 to 5 millimeter from the inferior tarsal border. That's where you make your incision. Ledge the inferior orbital margin with a large lid spatula. Dissect tissues. Our aim is to go to the inferior orbital margin right away without much of soft tissue dissection at all. Incision is made just a millimeter from the inferior orbital margin, not to injure the infraorbital nerve at all. Then you go on dissecting till you see one of the two endpoints, either the apex of the inferior orbital fissure or the infraorbital nerve, beyond which you don't want to disturb the periorbita, because then you will have consequences. But then there are these blood vessels which are passing through the bone. These are perforating vessels. They need to be cauterized, otherwise they will continue to irritatingly bleed and obscure your visualization. That was the infraorbital nerve at the bottom below. Now we make a periorbital incision right in the quadrant where the tumor is present. Just 30 more seconds. Dissect the tumor to about 30 to 40%. Then we go little posterior, and when the tumor is 2/3 dissected, we bring in the cryoptope to assess its ballotability. And if the tumor is ballotable, we support it from the posterior aspect and gently wriggle the tumor out. There is no hurry at all here. And hemostasis is very important during surgery. As the tumor comes out, we will definitely visualize this posterior pedicle, vascular pedicle, which is the feeder blood vessel that needs to be cauterized. Sometimes the MRI specialist himself tells us that this is the vascular feeder vessel from where the tumor derives its blood supply. It's easy for us then. Now lateral canthotomy incision is closed and inferior pharyngeal incisions are all vicryl absorbable sutures, and canthotomy sutures are also very small vicryl sutures. So patients do well, and this is the same patient after 2 weeks following surgery without any stigma of orbitotomy. Similar surgeries in adults as well, and this is a large tumor dissected. This is a neurolemoma. You can see the infraorbital nerve involved and the infraorbital nerve removed along with the tumor. That's the infraorbital nerve from which it was arising. So in conclusion, I would say that there are a lot of innovations in orbital surgery that we have advantage of, such as injections, even external beam radiation for many tumors, even benign tumors which are otherwise difficult to excise or may have functional implications, and of course minimal excess orbital surgery, which is very precise with much better outcomes than we used to have before. Thank you so much.
Hello. Thank you, sir, for the beautiful insight. Sir, I have a question for you. In cases of orbital dermoid, so how much time duration you keep between the two injections, if at all?
At least 6 weeks.
At least 6 weeks.
Yes. And then re-image the patient and then see how much the lesion has collapsed. If it is partially collapsed, then we can actually go in and do the repeat injection. If it is nearly totally collapsed, then you don't do anything more.
And is it same that the amount of volume that we retrieve, that much only?
Absolutely right. But then the foam is the same. Suppose you aspirate 5 cc of contents of the dermoid, the foam, the final version of the foam is the same. But for foaming, I would take 1/5 of the volume. Suppose I aspirate 5 cc of the contents, I would use 1 cc of sodium tetradecyl sulfate and foam it. Foaming increases its volume. And also foam has surface tension, so it will go and coat the walls. Otherwise, if you inject a liquid within a lesion, then the liquid will by gravity settle at the bottom, right? It will not cover the entire wall. And the implications of injecting 5 cc of sodium tetradecyl sulfate without foaming is that there will be very severe inflammation. That's the reason why we foam it.
Thank you, sir. Any questions?
Yeah. Perilesional rituximab is something new, and we have had a very small series everywhere. Me and Dr. Hakan Demirci from Detroit, we are working together on this. He's also injecting, I'm also injecting. So we have a combined series of about 8 patients now. And all of them have done well. There is uniformly no patient without response. These are specifically for very small residual orbital tumors where you think that radiotherapy is an overkill, or where radiation is relatively contraindicated. Like radiation is relatively contraindicated in a patient who has already diabetic retinopathy or is a patient who has diabetes, because those patients are likely to have accelerated diabetic retinopathy even with low-grade radiation. So in such patients, or patients who don't want radiation at all for any reason, or if a patient is already one-eyed and you want to avoid any side effect of radiation, then you select out these patients for intra or perilesional rituximab. B-cell lymphoma. B-cell lymphoma. Yes. No. No. Microcystic responds poorly. Macrocystic responds excellently well. But most of the tumors are a combination of both. There is one microcystic element followed by macrocystic. So it's a good idea to inject first, and then if the patient doesn't respond, then you can go for surgery. Yeah. Yes. Well, yeah, my pathologist is Dr. Mule. I totally leave it to him, whatever is appropriate. My intention is to allow him to independently do whatever he thinks is appropriate and give me the information that I need. So when do we need it? Basically, if you are operating on a patient where you don't know what the lesion is, even with the best of MRI specialist interpreting it and clinically we are putting all our thoughts together, then we have a situation where the patient is under anesthesia and we have to take a decision whether to go ahead and completely excise it despite all the morbidity that the patient may suffer. The lesion may be infiltrating the lateral rectus or SRLPX complex, or okay, now we have reassurance that it is indeed a granulomatous lesion. Now let's not do anything further and leave it for medical treatment. Those are the precise situations where I would keep my pathologist on the standby, keep the frozen section machine on, and he has this imprint cytology and squash imprint to his advantage. Right. So we do that while the patient waits under anesthesia, and then we decide whether to completely remove it or leave it there, because then, okay, it's granuloma, it is medically treatable. Sometimes we have found that even soft tissue sarcomas can present like granulomas, and yes, so patients are counseled appropriately. If it is a soft tissue sarcoma and it is, say, I know that, okay, it is a soft tissue sarcoma, now I know that, well, it can be treated by external beam radiation and perhaps chemotherapy or a combination of both, then I won't do any further intervention. But say lacrimal gland tumor, adenocarcinoma of the lacrimal gland, it's a completely surgical disease. There is absolutely no treatment choice that is available, such as chemotherapy, radiation. Some target therapeutic measures are coming up. In such a situation, what would I do? I would completely remove the tumor irrespective of what may happen to the superior rectus LPS complex. So that kind of counseling always happens before.